Okay, welcome back. I'm Professor Adam Thompson, and this is sort of a continuation of part 2, and you can call this video 3 in the 12 ECG comprehensive course. All right, let's go on to the PR interval. The PR interval, you certainly learn a lot about this when you're doing rhythm recognition and interpretation. It should be less than 200 milliseconds, which is one big box here, okay? Also, a lot of people know this as 0.20 seconds. Same thing, 200 milliseconds. It should be greater, the PR interval should be greater than 120 milliseconds, or 0.12 seconds. All right, so it could be too short. You don't want it to be too short. And we'll talk about some conditions that can actually cause it to be too short. Within the PR interval, you have what's called the PR segment. Segments are always lines that should be pretty flat. Intervals always include a complex or a wave. That's an easy way to remember that. So the PR segment actually begins at the end of the P wave and ends at the beginning of the QRS complex. And that PR segment could be elevated, and it could be depressed. And that could be a different sign of possible infarction or injury, right? It usually indicates, if it's PR elevation, it's going to usually indicate something benign, like a poor baseline. However, it could indicate atrial infarction, so it could be bad. It's all about the company it keeps. Look at your patient. Is your patient sick? You know, is your patient presenting like somebody who's infarcting? But, you know, this isn't something where you would call a STEMI, because, again, that's not the ST segment, and that's what the ST in STEMI stands for. So it's just one of those things to help you when you're identifying patterns. You may see something like this. So also you could have PR depression, all right, and PR depression could indicate something like acute pericarditis, right? Usually your viral pericarditis causes PR segment depression, or it could indicate an atrial injury, okay, which is like atrial infarction. Before you have infarction, you have ischemia and then injury, and that could be what the PR segment depression is actually indicating. Remember I said that the PR interval could actually be too short, right? It's too short if it's less than 0.12 seconds or 120 milliseconds, right? 3 small boxes. If it's shorter than that, it's too short. And that's usually caused by an accessory pathway. Something is bypassing the AV node, and your conduction is going straight from the atria to the ventricles. And let's talk about that for a second, because you know when you learn a rhythm interpretation that the P wave, that's your atrial depolarization wave, right? That's atrial depolarization. Then you get your PR interval. Let's draw this a little bit better here. All right, so we have a P wave. Then we have our PR segment. And what is the PR segment? What's happening here? If the P wave is atrial depolarization and PR segment is nothing, what's happening? Well, that's where conduction stops at the AV node. The AV node stops conduction to allow for good ventricular filling, right? We allow the atria to get rid of as much blood as possible, stretch those ventricles, get good Frank-Starling mechanism, and get good cardiac output. That's the idea behind that AV node, to allow for ventricular filling. And then so after that quick pause, you get a nice QRS complex, and then a T wave. That QRS complex is ventricular depolarization, and then the T wave is the repolarization of the ventricles. We know all that, right? So what's happening if we have a short PR interval and we go right into the QRS complex? Well, in that case, we're bypassing the AV node. And we're going to talk about some conditions that can cause that. So accessory pathways. These are pathways of conduction that are outside the normal pathways of conduction, okay? Wolff-Parkinson-White syndrome is probably the most commonly known and most popular. It's caused by something called a bundle of Kent. The bundle of Kent bypasses the AV node through atrioventricular conduction pathway, and it creates a shortened PR interval in your classic delta wave and widened QRS. So that's the 3 things you see right there, is a shortened PR interval, delta wave, widened QRS with WPW. And what is the danger of it? Well, you can end up with a very deadly reentry tachycardia. So that is the danger of WPW. And the reason I say deadly, because a lot of the medications we use to treat reentry tachycardias could make this potentiate a ventricular arrhythmia, ventricular fibrillation, or ventricular tachycardia. So it is deadly. And then Lown-Ganong-Levine syndrome, similar to WPW, you have an accessory pathway called the James fibers, which will kind of bypass the AV node in a different way, and it creates a shortened PR interval. You don't generally see a delta wave with this, and you don't usually have a widening of the QRS. Okay, so you have a normal P wave with a short PR interval, P wave, and then QRS almost immediately after. So let's talk in general about WPW, and then I'll go over the more specific conduction phenomenons that can occur. So with normal conduction, you have your SA node here. We go down the intranodal pathways here, across Bachman's bundle here to the left atrium. All right, this all kind of occurs really quickly and almost simultaneously. And then the atria will depolarize, and you get this nice pause here at the AV node, allows for the ventricles to fill up, and then you go down the His bundle into these bundle branches and Purkinje fibers, and you get some ventricular depolarization, and everything happens nice and rhythmically for good cardiac output. Now, WPW says, I don't like that. So with WPW, yeah, sure, you got this nice SA node, which is probably your pacemaker, but it could change, right? Let's say over here I have an accessory pathway. Now, what does that mean, an accessory pathway? That means that there's nothing blocking conduction from the atria to the ventricles. In fact, this is a nice, fast pathway of conduction. So what's going to happen? Well, you'll get your depolarization will start here. It will still go across Bachman's bundle. You'll still get it down here, down here, down here. It will go to the AV node, but it's going to like this path a lot better because this is the path of least resistance. And it's going to go down here into the ventricles pretty quickly. This is still going to continue on as well. And that generally is what you'll see happen. So you'll get a combination. So from this side, with down the normal conduction, we get what looks like normal conduction. Okay. So you have a nice PR interval here, and that's normal conduction. But because, I'm going to use a different color, of this accessory pathway over here, okay, now we get to the ventricles faster. All right, we get to the ventricles faster, so it starts to depolarize the ventricles a little bit sooner, all right? And then, since we're outside of the normal fast pathways of conduction over here, let's switch back to white, and we have to go from cell to cell to cell to cell to depolarize, because you're not in those bundle branches, you're not in the His bundle. And that's why you'll get a widening of this QRS complex, okay? And that's what's going to happen. And that's what you'll actually see. So you'll see a normal P wave, and then this big delta wave widened QRS complex, and that's your typical WPW presentation. So you can actually have different types of conduction patterns with WPW. You could have your normal physiological conduction, right? The accessory pathway could just, not be working. You could still have a Kent bundle, and it's not being utilized. Or, more commonly, like we said, you could have what we call pre-excitation. That's what this is called, pre-excitation. Okay? And that's when, here, let me put pre-excited. Pre-excitation. That's when you have conduction that goes both down the normal physiological pathway and down the Kent bundle or the accessory pathway, and kind of meets up, but you're going to see that you have a shortened PR interval, a delta wave, all right, so short PR interval, that's here, this slurred up slope of the QRS, that's called a delta wave, and a widening of the QRS complex because the ventricles start getting depolarized a little bit sooner than they should, and that widens the QRS complex. And the reason that it doesn't just, take over on this side is because we're outside of the normal conduction pathway, and we know we're going from cell to cell to cell to cell over here to depolarize, while over here, even though it takes longer to get to the ventricles, once we get there, we sort of depolarize a lot faster, and that's why they both kind of merge together. So again, your classic triad for WPW, if you will, is a delta wave, which is a slurred upslope of the QRS complex, shortened PR interval, and a widened QRS complex. You could also have what they call antidromic or orthodromic induction, but we'll talk about antidromic reentry because that's the scary one. Antidromic reentry is when conduction goes, it doesn't follow the physiological pathway at all. It just goes down here through the accessory pathway, comes back up. Now it's coming back up in an antidromic fashion through the normal physiological pathway back towards the atria, and you're going to get what they call a re-entry phenomenon here. And those can get pretty fast. And this can degrade into a ventricular tachycardia pretty quickly, so you need to be ready to treat these patients. So just looking at a couple examples, here's an actual 12-lead EKG of somebody who has Wolff-Parkinson-White syndrome. And it's very apparent in a couple of the leads, but just looking at lead 1 from the beginning, okay, do we see our triad that we talked about? I think you'll recognize that we do. All right, we have a P wave before the QRS complex, but that PR interval is really short, isn't it? So you have a shortened PR interval, and then you do have that slurring upslope of the QRS complex. It's sort of difficult to identify here because the QRS complex doesn't look too wide, but it's wider than it normally would be. It's certainly wider than it normally would be because those ventricles are depolarizing much earlier than they should be. So look over at V4 and you can kind of see that classic triad pretty good too. All right, shortened PR interval, slurring upslope. That delta wave is much more apparent here. Okay, slurring upslope of the delta wave and widening of the QRS complex. Also in V3 you can see it pretty nicely. It does work in the opposite direction, so if you have a predominantly negative QRS complex, as we do here in lead 3, okay, you still can identify these different findings. It just might not look as natural to you, so you do have a little bit of a P wave there with a shortened PR interval, and that slurred upslope has become a slurred downslope here with a widened QRS complex. Here I've kind of blown it up for you. So again, shortened PR interval, slurred upslope, widened QRS complex. Classic triad for a pre-excitation of WPW. Here's one where the actual 12-lead EKG tracing is not as clear. This is what we would call a wandering baseline. This patient probably had some severe dyspnea or something, was moving around a lot. But what you can gather from this, just by looking at lead 1, is that the patient has WPW. Shortened PR interval, slurred upslope, wide QRS. This QRS complex is much wider than the previous one that we saw. Here we have another great example of a patient with WPW. Look here at lead 1, and you'll kind of notice the trend here. Lead 1 does present very often with a nice presentation of the triad, short PR, slurred upslope, delta wave, maybe a little bit of widening of the QRS complex. You could certainly see again in V4 the shortened PR interval in the delta wave much clearer there as well. And in V2, to me, this one is actually the most obvious because that slurred upslope delta wave and the P wave goes right into the QRS complex. When the P wave goes right into the QRS complex, that's pre-excitation. There's almost nothing else that will cause that. Maybe a junctional rhythm, and again, LGL, which is another type of accessory pathway that can cause pre-excitation. So I want to talk real quickly also about WPW when you have somebody that goes into an arrhythmia or a dysrhythmia and they have WPW. We talked about VTAC, so a patient can go into ventricular arrhythmias, but also atrial fibrillation. Atrial fibrillation, and what's scary about this is normally AFib isn't that much of a problem because the patient can go into AFib and that AV node is the gatekeeper. So AFib is when the atria are quivering, they're depolarizing 800 times a minute, like super fast, right? But all those depolarization waves ain't going to make it down to the ventricles. If they did, you'd have VFib, right? You'd have ventricular fibrillation. But they don't because the AV node does a good job at saying, hold it up, let's stop only give me a few of those signals, and I'll depolarize the ventricles when I want, right? And it still creates a tachycardia, but a much more controlled rate. And we can control it by actually giving medications that affect the AV node and make it work a little better. However, okay, when you have an accessory pathway, there is no gatekeeper. The AV node is there, but there's no gatekeeper at the accessory pathway, and that will become the path of least resistance. This patient is at extreme risk of a very fast tachycardia. We're talking 300, 400 beats per minute because there's nothing to stop those rapid depolarizations from coming down to the ventricles with that accessory pathway. And the pathognomic presentation of AFib with WPW is easy to remember. FBI, fast, broad, and irregular. And when I say fast, I'm telling you it's very fast. It's very wide or broad, and it's very irregular. It's irregular in both morphology and rhythm. Okay, so it's fast, broad, and irregular. In that case, you're going to want to stay away from AV nodal slowing agents, like calcium channel blockers especially. If you give cardizem to this patient, you could kill them because getting rid of the gatekeeper, the one gatekeeper, is going to create re-entry tachycardia, VFib, things that aren't going to be too pleasant. Okay, so AFib with WPW is really bad. The only other thing that will cause that fast, broad, irregular rhythm is AFib with a bundle branch block, but WPW is going to be much faster. So what's the treatment? That's what you want to know, right? What is the treatment if you can't give your AV nodal slowing agents? Cardioversion. Because I promise you, so this patient has WPW. They probably had WPW for a while. They just went into AFib. The fact that they're in AFib with WPW lets you know that this happened relatively acutely and not too long ago, because if they were in it for a while, they wouldn't survive. It's too fast. They would pass out. They wouldn't be around. This is going to be something that was short-lived, so it's pretty safe to cardiovert this patient. In fact, it's the best treatment. Get them out of that rhythm. Get them out of AFib. Get them into a sinus rhythm where yes, they'll still have WPW, but it's not going to be as fast, right? So that's the idea. Cardiovert this patient because you don't have to worry about, heparinizing them or anything like that. You know that it's a short-lived tachycardia. So here is one example of a rhythm that is fast, it's broad, and it's irregular. This is probably not AFib with WPW. Yes, it's fast. It's not that fast. Yes, it's broad. It's not that wide. And it's irregular, but it's not that irregular. This is your AFib with a left bundle branch block. However, whenever you have a wide complex tachycardia, you're going to not want to go straight to something like a calcium channel blocker. Let's be safe here. There are safer alternatives. If this was AFib with WPW, and let's say it was stable and you wanted to give a medication, I know I said cardioversion is the primary treatment. That's how I feel about it. But procainamide is also a safe option. If you have procainamide available, you can certainly administer a dose of procainamide. And here you go. Here's another fast, broad, and irregular rhythm on a 12 EKG. And you should notice that this is much faster, it's much wider in certain areas, and it's much more irregular, as in the morphology and the rhythm. Okay, and you'll notice at times this is 300 beats per minute. This is a very, very fast tachycardia. This patient isn't going to survive very long. I'm a big believer in cardioverting this patient. As soon as you see this presentation, sedate them with your favorite sedative, get them nice and sedate, cardiovert them, get them into a much safer rhythm, something that you can actually manage. As I said before, there's also something called Lownganong-Levine syndrome, LGL, which could also be another type of accessory pathway that presents with something called the James fiber that bypasses the atrioventricular node, and it creates a shortened PR interval. You don't get that delta wave, you don't get that wide QRS complex, but you are at risk for reentry tachycardias and preexcitation. So what's the take-home message when it comes to accessory pathways? The take-home message is recognizing the presence of an accessory pathway is much more important than the ability to differentiate between the different types of accessory pathways, right? Once you identify that somebody's got an accessory pathway, you know they're at risk for reentry tachycardia. If you see that FBI, that fast, broad, irregular rhythm, be ready to treat it. Also know which medications to stay away from. Your calcium channel blockers are a big no-no when you're dealing with accessory pathways. And keep that in mind. Even amiodarone is not the safest medication. If you look at the research, you could definitely have some ill effects after administering amiodarone. So that's the end of the third video here. You can always go back and watch any of the other videos or move on forward to the next one. As always, don't forget to click and subscribe if you're watching through YouTube.